let's start. Well, the role of BTA in abdominal wall reconstruction, there is always, well, can you put it up the screen? Yes. It would be more interesting, because I know that, but...
Maybe the volume also go.
Yeah. Okay. Thank you. Well, sometimes some people change your life. And this guy has changed mine too. This is Tomas Ibarra from Mexico, from Guadalajara. I visited him about 9 years ago and started using what he taught me. Well, my disclosures, you already had that. I have no conflicts of interest. There is no company there that uses any botulinum toxin product. Maybe it is too loud, because otherwise it's... Okay, well, botulinum toxin is a major bioweapon. We hear stories about that, how important it would be in the case of war. It's incredible. It's easy to produce it and easy to misuse it, because there is 1 single gram of botulinum toxin that can kill more than 1 million of people. So use it with respect. Well, the 2 guys who are in these newspapers are sitting here with us. I said from a major bioweapon to wonder weapon for groin hernias. And then I said, well, do you think it's better? Even better. Or whatever, thank you. Yes, wonder weapon for inguinal hernias. Well, there are groin hernias that deserve to be treated with Botox preoperatively, the ones that end up down here. So this is how you produce fake news anyway. But let's use the correct expressions. We very often mix it up, because botulinum toxin is a group of serotypes from A to G, and the Botox is just a trademark. And still we talk about it like it would be representative for all botulinum toxin. There are various products, and what is important about that, first, they don't do any component separation, but they do components relaxation. This is the first. And second, there are different quantities to be used to reach the same effect. So again, the trademarks are important. It's not for propaganda for any product. Well, they are BTAs and BTBs. Well, I've heard that. It's not such a long time since I got to know about the existence of the BTB, which is BioBlock or NeuroBlock. The specific difference is that the action comes much faster than with the BTAs. And like everybody knows, Dysport, Botox, even the Chinese have their own BTA now. And so the question is then, what do I use, how many units I need for the effect that I want to reach? And this is what we discuss. The second part of that is the role of BTA in complex hernias. What is complex? Then when it is difficult, or what is complex? There is a kind of definition of complex hernias, which was made by a group around Slatter, and they defined 4 different categories of complexity and 3 severity classes. And it's all about guidance of perioperative planning, the risk of complications, and the extent of financial cost when you're treating these patients that need BTAs as a prehabilitation. Well, size and location, I don't want to go into deep here, but certainly a special group of patients that have loss of domain, which is more than 20%. You all know the Tanaka formula, and the contamination and soft tissue condition is another factor of complexity, denervated muscles, open abdomen, presence of enterocutaneous fistulas. It's all propedeutic. The patient history and risk factors. something that we cannot change. That's what the patient bring with them, and we have to be thinking about it, how important it is when there was early a mesh repair, component separation, or something that we've heard about, the vascularization of the abdominal wall because of the previous surgeries. That makes the decisions much more difficult. Well, factors that impair wound healing, and the increased intra-abdominal pressure, which is in obese, the rule. Previous wound resistance, previous mesh infection. Well, the clinical scenario, of course, that the emergency surgery has got more difficulties because very often not the appropriate team is on work. So the emergency surgery has got worse results. Intraperitoneal mesh removals and multiple hernia defects and so on and so on. Well, no primary, oh, that was too fast, sorry. Well, talking about abdominal compartment syndrome like we did once last year with the Indian friends, took us 9.5 hours with 25 speakers talking about very little segment of herniology, and it was absolutely fantastic. It's important because it's got its consequences. Well, what is exactly mean by loss of domain? That's a very nice expression. It's just a relationship between hernia and abdominal volume, and uses to predict operative difficulty or success of the repair. Well, there are several facilitators, as I call it, add-on techniques that increase the capacity of the abdominal cavity, but I don't want to talk about it. I want to talk about this one, about components relaxation by BTA, maybe in together with the intraoperative fascial traction, something which changed a little bit our strategy when dealing with large or huge hernias. Well, what for? I know that it is propedeutic, but there are many things that are propedeutic that we never talk about, and then we end up after 10 years, how come that you still don't know this or that? So don't blame me if I'm too simple. It elongates and flattens the muscles. We saw a very nice example this morning. It lowers the intra-abdominal pressure at the defect closure at the time and lowers the risk of abdominal compartment syndrome. It's a logical preoperative optimization, and I say it today, it is logical because we all do it and accept it as fact. It wasn't like that 9 or 10 years ago. Well, it extends the time of closure to the healing of another 5 or 6 months. That improves actually the chances for a good healing with the difficult hernias. And that temporarily, in comparison to something that partially destroys the anatomy of abdominal wall when using component separations. How? Well, it's a muscle mass dependent dosage, so you inject there where the muscles are, not at the medioclavicular line or whatever. You have to consult your CT scan of the patient and then realize where can I inject that agent. Normally it is about 100 units of Botox or 300 of Dysport per side. I use the 5 points locations. There are techniques that use only 3 points of injection, but I think that is not such a big difference. As you see here in this example, after the injection in the retracted muscles, the muscles elongate. It takes about 4 weeks to take the effect, and they get flatter and they give much better chance at the time of closure. We see it especially when we use the intraoperative traction that these muscles are somehow softer. They are easily to stretch. Well, this is from Thomas Ibarra. Well, it is showing that you can inject in several muscle groups, but he gave us a nice example injecting even in the rectus muscle when it came to the point with huge inguinal scrotal hernias, just to increase the total capacity of the abdominal wall. Abdominal cavity, sorry. What about quantity, dilution, and safety? Well, the team from Sydney tested it. They compared 300 units with 200 units of Botox and came to the same result. So maybe you can save your 300 and reduce it to 200. I always used 200 units, and I think it was enough. Well, Ibarra dilutes only with 20 cc's and injects at 10 points. That makes 2 milliliter per injection. The team from Sydney uses 6 points and dilutes with 150 milliliters. Can you imagine to inject in the abdominal wall of a slim patient 25 cc's per injection? I don't know where they put it, but this is the way they published it. Well, about safety, well, we've been worried in the beginning because we didn't know what we should expect from that, what happens within the first 4 weeks until the operation. Actually, nothing happens. The patient realized that they became more transverse as they were before because the capacity will enlarge. And actually, when you compare the quantity of the units that are used, it should be there that Botox, 100 units means 250 or 300 units of Dysport, and the Chinese one needs just 150 units. Well, this is Nabil Ibrahim from Sydney, who's injecting his 20-25 cc's in one injection point. That hurts. And probably you cannot stop the diffusion of the fluid. So when they talk about injecting only 2 muscles instead of 3 muscles, it does not make much sense when you need such a high volume. Well, there are easier way of doing it. This is Rigoberto Alvarez that injects it in his office with very simple, just studying the dips on the CT scan and then just take a ruler and a sterile forceps and then you do exactly the same. If you don't have the access to good sonography. Well, this was my first patient. Actually, he came with a defect of 16 centimeters and the width of the defect diminished preoperatively after 200 units of Botox, 207 millimeters. So I gained about 5.7 centimeters preoperatively already. And actually what happened with him after that, well, as I said, they become transverse, the patients, and they feel it somehow. But there is no respiratory consequence of that and not stability of the spine, because we all say that the transverse abdominis is the biggest or strongest stabilizer of our spine. Well, 4 weeks post-op, it's not because of that, because it is the patient that makes the result in the end, because he was so motivated. He's got a younger wife, and then he was, after 5 operations, standing like this. So, and this is how it looked after 11 months. And, well, he's doing well. He's a tough guy. Well, what happens with the muscle when they are unloaded? This is very interesting, that it changes fiber type composition. So fiber type means moving muscle like the rectus or the stabilizing muscle like the transverse abdominis. They lose elasticity, they deposit collagen. So the longer you wait with your operation, the more ground you are losing. They become stiff. Well, maybe it goes too far, it's repeating. Well, it lowers the intra-abdominal pressure, which is clear, but this makes the diaphragm get lower and it causes a respiratory dysfunction. Well, this is just an example of that the BTA can, in some cases, prevent the use of component separation. That's a paper that Jorge, you definitely know, Ezequiel Palmisano, Argentina. 38 cases, ventral hernias over 12 centimeters of diameter. No one needed component separation. Thanks to BTA, they could close them all. No bridging repairs. And what is more sustainable in the end? Is it a calculated permanent partial destruction of the abdominal wall? This is how I call the component separation, although I use them because very often I cannot close them primarily, so I take all possibilities that I have to close. Or is it a temporary reduction of the muscle tone with spontaneous restitution? Well, there are many questions and we don't have that many answers, and this is a quite clever comment on that. Who he knows all the answers probably has not been asked all the questions. Well, my conclusion, BTA has a strong potential to facilitate complex repairs. BTA, with or without PPP, enables primary closure and may prevent definitive partial damage to lateral abdominal wall. And BTA decreases the pain perception. This is a very interesting effect. It's not the different tonus, because it comes already after 3 or 4 days, this effect. These patients nearly have no pain after huge repairs. And this is a very positive effect. And still, as far as I know, it's not known the mechanism, how it works, but it does. Well, for me, there is absolutely clear indication for large, for W3 or even giant hernias. Although it is still off-label therapy, in some countries it's covered by the healthcare systems, like in Spain, Denmark. I spent several years to convince our insurance, and they cover the Botox therapy preoperatively in every case today. So the preoperative optimization is an essential to obtain the best possible outcomes in terms of fascial closure. Did you switch off that machine that causes? Yeah? It's very kind of you, because I will finish now. Imagine. Yeah. Not everything that counts can be counted, and not everything that can be counted counts.